We're going to present now Dr. Kofi Oteng Boateng. Dr. Kofi is an oral maxillofacial surgeon trained in New Zealand and Australia. He was awarded the surgical fellowship through the Royal Australian College. He currently holds a visiting surgical specialist at the St. John's Hunter Hospital in New South Wales, and also in a private practice in Westmead Private Hospital. Thank you.
Ladies and gentlemen, thank you very much for the opportunity to come and speak to you today. I will be talking to you on medication-related osteonecrosis of the jaw. So a quick outline, I'll discuss the definition, which medications put patients at risk. I will look at the pathophysiology, the risk factors and patient assessment. I will also discuss management and prevention. I will briefly look at dental implants and anti-resorptive bone medication. This is a question I do get a lot of inquiries about from my dental colleagues, and I will also give some recommendations. So medication-related osteonecrosis of the jaw, there are three things which you need. You need to have exposed bone in the jaw for longer than an 8-week period. There needs to be no history of radiotherapy to the jaws, and the patient needs to be currently treated or previously treated with a bisphosphonate medication, a rank ligand inhibitor, or an anti-angiogenic medication. Now, some older texts, they do refer to this particular disease as a drug-induced osteonecrosis of the jaw, or a bisphosphonate-related. So they're all the same thing. So look, the presentation, it can be quite mild. Over here we can see that there is an ulcer, an exposed bone in the right posterior mandible on the lingual aspect. Sometimes this is the type of presentation you may see. It can also be a bit more severe. Here you can see there is quite extensive necrotic bone on show. Here's another case. And sometimes it can be quite extensive where there is a lot of exposed necrotic bone. It can even lead to a pathological fracture, and sometimes it can be extraoral manifestations of the disease process, where you have the draining sinus and infection under the chin. So this particular disease phenomenon, we became aware of it in about 2003, and it was the bisphosphonate medications which were the main risk group. Now the thing about this particular class of drug is it irreversibly binds to bone, and it has a half-life of 11 years, and it decreases bone resorption and remodeling by inhibition of osteoclast differentiation and function, and by causing apoptosis of the osteoclast. Now there are two main types. We've got the oral and the intravenous types. Now anti-resorptive bone medication, they're most commonly prescribed for osteoporosis, for management of bony metastasis, and also the management of multiple myeloma. So those are the three diseases where I most often see patients developing MRONJ, medication-related osteonecrosis of the jaw. However, patients who do have Paget's disease, primary hyperparathyroidism, osteogenesis imperfecta, and fibrous dysplasia are also at risk of developing MRONJ. So what is the mechanism? So the medication reduces bone turnover, and there is an excessive reduction of bone turnover, which leads to a risk of osteonecrosis when repair is needed. So with the pathophysiology, essentially there are three things that you need. You need inhibition of the osteoclast. You also have an inflammatory or an infective component. So quite often the exposed bone ends up being colonized by bacteria or a biofilm from the mouth. And you then also have a process where there's inhibition of angiogenesis, and a combination of all three leads on to osteonecrosis of the jaw. So what are the risk factors? So first of all, we've got the medication, the route, the potency, and the duration of therapy. And you've also got dental alveolar surgery. So a patient who then subsequently goes to have a tooth removed at the dentist. However, one thing that you do need to bear in mind is a dental infection or a dental abscess can also lead on to osteonecrosis. And patients who are immunocompromised, being treated with steroids, diabetic or chemotherapy medication, are at an increased risk. So when you look at bisphosphonate medications, the potency is one of the biggest risk factors. So if we assume that etedronate has got a relative potency of 1, alendronate has a relative potency of 1,000, and zoledronate has a relative potency of about 10,000. Most cases of MRONJ occurs in the posterior mandible. Now, the interesting thing about medication-related ONJ is it only occurs within the jaws. You don't have it, it doesn't exist in any other part of the body. So what is it about the jaws that puts it at risk of developing MRONJ? And it is believed that because of the high bone turnover, so the jaws have got a bone turnover of about 10 times that of the long bones. So therefore, there is more deposition of the medication into the bone. It's also believed that the trauma from eating, the thin mucosal covering, and the bacterial environment all contributes to the reason why we end up with osteonecrosis in the jaws. Now, the majority of patients do present with symptoms of pain and infection, but the thing to bear in mind is about a third of patients who develop this, they are asymptomatic, and often it is the dentist who will notice that there is exposed bone within the mouth. So how common is this? Now, if we look at bisphosphonate medications, for the incidence is about 1 in 1,500 to 2,500 people. However, when we look at patients who are receiving the intravenous version of the medication, who are on it for cancer therapy, you find that the incidence is between 1 in 5 to about 1 in 15 people. Now, when you culture the bacteria from the necrotic bone, there are 4 bacterial species which are usually isolated. Now, the reason why that is of relevance is because all these bacterial species are more susceptible to penicillin than clindamycin. Now, the reason why I'm stressing that is I am aware that there are some guidelines, some New South Wales health guidelines, which do encourage the use of clindamycin. But in actual fact, when you look at the microbiology, it actually suggests that amoxil or penicillin would be a better choice of antibiotic. And this is what the American Association and the British Association of Oral and Maxillofacial Surgeons recommend. Right, so risk assessment. Now, before I proceed, I need to basically discuss about a serum collagen telepeptide test. Now, this is a blood test where it is a measure of bone collagen fragments which are released during osteoclastic activity. So essentially, it is an indirect measure of bone turnover. Now, there was a study by a Californian maxillofacial surgeon in 2007 where using this particular blood test, he was able to come up with a relative risk stratification where the CTX level of less than 100 units represented a high risk of developing MRONJ. A level between 100 and 150 was of medium or moderate risk. And the CTX level of greater than 150 was associated with low risk of developing MRONJ. What Marks also found from the study from 2007 was that patients who were on the oral version of the medication, they had a less severe form of MRONJ. He also found that if you were to put the patient on a drug holiday and cease their oral medication, that often the CTX score increased by 25 units per month. He also found that the duration of therapy was critical. So if a patient commences an oral bisphosphonate medication today, it's incredibly unlikely that they will go on to develop MRONJ within a 3-year period. So you can go ahead as a dentist and proceed with whatever treatment you need, and it's highly unlikely that they will develop MRONJ. For patients who have received, for example, intravenous zoledronic acid, the window period is about 9 months. So again, if you have a patient who has had their IV medication, first dose today, you can safely go ahead and proceed with removal of teeth, and the likelihood of them developing MRONJ is incredibly unlikely. So a bit more on the risk assessment. So the 3 things you need to take into account are the medication factors, the patient comorbidities, and the surgical factors. So with the medication, it's the route, the duration, the potency, and the indication for the medication. Patient risk factors are other medications such as steroids or chemotherapy medication, the age of the patient, immunosuppression, and if they're being treated for a malignancy. And surgical factors essentially refer to how many teeth that need to be removed and the difficulty of the required extraction and extractions in the posterior mandible. So when you take into account the patient factors and the surgical factors, you're now able to group patients into low or high risk, or a procedure into a low risk procedure or a high risk procedure. And then that gives you an overall risk for developing MRONJ, where you can stratify it into a medium, moderate, or significant risk. So these tables are taken from the New South Wales Health Guidelines, and a low-risk patient is a patient who is on Fosamax, for example, an oral bisphosphonate. A low-risk procedure, a patient who undergoes a routine dental extraction. A high-risk patient is a patient who's been on long-term anti-resorptive bone medication, or those patients who are outside that window period of 3 years for an oral medication, or about 9 months for the intravenous version of the medication. Patients who are being treated for malignancy or multiple myeloma, patients above the age of 70, and patients who are also immunosuppressed or are being treated with steroids, not necessarily for malignancy, but for some other autoimmune condition. And a high-risk procedure is a patient who requires multiple dental extractions or the extractions are going to be very difficult. So a low-risk patient undergoing a low-risk procedure puts them at minimal risk of MRONJ. If you have a low-risk patient or a low-risk procedure, if you have a high-risk patient or a high-risk procedure, that puts them at a medium risk. However, a high-risk patient undergoing a high-risk procedure, they are at significant risk of developing MRONJ. And once you know which group they fall into, that then gives you a little bit of an indication as to how the patient should be managed. So a patient who is considered as in a minimal risk group, you don't really need any special precaution per se. You know, as a dentist, you can go ahead and proceed with extraction. A medium risk group, you should consider the use of prophylactic antibiotics, or a patient at significant risk should have, antibiotics prescribed for a longer period of time. Right, so the extraction protocol that I often use is where the patient receives 2 grams of amoxil an hour before the procedure, chlorhexidine mouth rinse immediately before. During the procedure, you want to be as gentle as you can and encourage bleeding. Try gain primary closure of the wound by just trimming the alveolar bone edges so that the mucosa folds over and you can suture it. Post-operatively, I put the patients on between 5 to 10 days worth of amoxil, really depending on their risk, and they are followed up closely. Now, if MRONJ does occur, just localize debridement with the use of antibiotics and sometimes a rotational mucosal flap to gain primary closure is what you need to do to try and resolve it. And you just also need to treat any other sequelae that can occur. So if we go back to this lady here, she was a 70-year-old lady who was referred to me by a local head and neck surgeon. She had been on clindamycin for a 3-month period, yet she continued to have pus draining out of a sinus in the right mandibular region. So the OPG revealed her to have a pathological fracture. So for her, after I performed localized intraoral debridement and repaired the intraoral wound, she then required an excision of the fistula.
5 minutes.
An exposure of the fracture site with localized debridement. And then she then subsequently had to undergo fixation with what we call a reconstruction plate. And, she had everything recovered quite well. Now, this particular medication, Prolia, initially when it came onto the market, we were of the belief that it would solve all the problems we had with RONJ. So Prolia is a monoclonal antibody for the it's a rank ligand inhibitor. It is an alternative to a bisphosphonate. But one of the main advantages of this medication is it only has a half-life of about 32 days, so it's deemed as being irreversible. And that's the reason why, after about 5 months, the serum concentrations are quite minimal, and that's the reason why, doctors prescribe it 6 monthly. So how does Prolia compare to bisphosphonates? So this particular study here from 2015, there were a total of 9,000 patients who were being treated for solid tumors, and what they found was the relative risk of developing osteonecrosis of the jaw was about 1.48 compared to an oral bisphosphonate. So in other words, a patient who was receiving Prolia, they are they're 50% more likely to develop RONJ compared to a patient who is on an oral bisphosphonate. Okay, but remember I mentioned earlier that the overall risk with the bisphosphonate was about 1 in 1,500. So you can see that the overall risk is still quite low. So I've got, I think, about another 3.5 minutes. So I'm just going to quickly discuss anti-resorptive bone medication and dental implants. This is a query which I often get a lot of dentists asking me. Is it safe for a patient who is on an anti-resorptive bone medication to have an implant placed? So let's have a look at this systematic review from 2016. What they found was there were a total of about 530 patients who had been on a bisphosphonate medication. There were a total of 1,330 implants placed, and 113, or about 9% of them, were lost. And 15% of patients went on to develop osteonecrosis. And what they also found when they looked at those simulate cases of osteonecrosis was it was most often in the posterior mandible. Now, when we have a look at the individual studies that were used for this particular systematic review, you can see that patients who were receiving an oral bisphosphonate because of osteoporosis, there were absolutely no cases of RONJ, or osteonecrosis of the jaw. When we look at the cases where the patient was on an IV bisphosphonate, often due to malignancy or multiple myeloma, that was where all of the cases of RONJ occurred. So you can see if you have a patient who is on an oral version of the medication, the likelihood of them developing osteonecrosis of the jaw is incredibly unlikely. Right, so what's my recommendation? So I think that it is important, for the doctors here, the medical doctors, that before commencing a patient on an anti-resorptive bone medication, it is important that you do mention to them the risk of developing osteonecrosis of the jaw. You should have them go see their dentist for a very thorough assessment. And for the dentist, any tooth which is compromised or infected should either be treated or removed. You do need to encourage the patient to have regular dental checkups, 6 monthly. For the GPs or the doctors, I would consider using denosumab rather than zoledronic acid if it's clinically appropriate. And the reason for that is denosumab only has a half-life of 32 days, and it's a lot easier to manage cases of ONJ or RONJ in patients who are on denosumab compared to zoledronic acid. So in summary, RONJ, the incidence with oral medication is about 1 in 1,500, whereas IV cases of RONJ relating to an IV medication is up to about 20%. RONJ can be caused by dental and periodontal infections. Quite important, it's not just about having a tooth removed. The bacteria associated with RONJ are more susceptible to penicillins. Denosumab is associated with an increased incidence of RONJ compared to an oral bisphosphonate. Do consider a drug holiday if you deem a patient at risk of developing RONJ if they are to undergo a dental extraction. And lastly, dental implant placement is not necessarily contraindicated in patients who are on an oral bisphosphonate. And there appears to be minimal risk with osteoporotic patients. And if there's any doubt, please refer to your local oral and maxillofacial surgeon. Thank you.